Ladies and gentlemen, welcome to today's presentation. My name is Dr. Aurangzeb and I am working as a cardiologist at Sedu Teaching Hospital in Swat. In today's presentation, we are going to talk about triple antithrombotic therapies, balancing the risks and benefits. Triple antithrombotic therapy involves the combination of three antithrombotic agents and is commonly prescribed to patients with specific cardiovascular conditions. From our day-to-day practice, we know that there are patients who already have an indication for either oral anticoagulants or for dual antiplatelet therapy. For example, patients with atrial fibrillation or patients with mechanical heart valves or patients with VTE are on anticoagulants. On the other hand, patients with coronary artery disease or who have undergone PCI are taking dual antiplatelet therapies. However, for these patients, scenarios may arise that might compel the use of triple antithrombotic therapies. So today we will explore the rationale, indications, risks, benefits, and best practices for managing triple antithrombotic therapies. Let's define triple antithrombotic therapies. Triple antithrombotic therapy combines three types of antithrombotic agents: oral anticoagulants, which can either be warfarin or novel oral anticoagulants, the antiplatelet agents, aspirin or P2Y12 receptor inhibitors, clopidogrel, prasugrel, ticagrelor, or the intravenous agent cangrelor, or antiplatelet glycoprotein 2B3A inhibitors, for example, exeximab. The goal is to prevent thrombosis and reduce the risk of stroke, myocardial infarction, and stent thrombosis in patients with specific indications. Indications for triple antithrombotic therapy can be many. Triple antithrombotic therapy is typically prescribed in the following scenarios, namely patients with atrial fibrillation or mechanical heart valves who are already on oral anticoagulants, have acute coronary syndromes or percutaneous coronary interventions. Vice versa, a patient who has post-PCI with stent placement and now has developed atrial fibrillation, and also post-PCI with stent placement and high risk for stent thrombosis, and patients with a history of stroke or transient ischemic attack undergoing PCI. The four clinical scenarios that should be remembered are patients who have atrial fibrillation who are prescribed anticoagulants and suddenly the need for PCI arises. So in this clinical setting, you will definitely require or may consider the use of triple antithrombotic therapies. Or a patient with coronary artery disease on antiplatelet therapy has new onset AF, already on dual antiplatelet therapy, and now the patient has developed atrial fibrillation. Definitely this patient can be considered for triple antithrombotic therapy. So this is the second clinical scenario. The third clinical scenario are the patients who have prior venous thromboembolism. They are on anticoagulants and suddenly the need for PCI arises. Another scenario in which triple antithrombotic therapies may be considered. And finally, new or recurring venous thromboembolism requiring anticoagulation in a patient already on antiplatelet therapy for coronary artery disease. These are the four clinical scenarios that you can come across which may require the use of triple antithrombotic therapies. Rationale and the benefits of triple antithrombotic therapies are that the triple antithrombotic therapy addresses the dual need for preventing thromboembolic events and stent-related complications in high-risk patients. Benefits include a reduced risk of major adverse cardiovascular events, including stroke, MI, and stent thrombosis in the short term. And it may also prevent thrombus formation around mechanical heart valves, lowering the risk of valve dysfunction. However, it is not free from risks and complications, and the most important risk is major bleeding, which is the most significant concern with triple antithrombotic therapy. These can be intracranial bleeds or visceral bleeds, major bleeds that can lead to death, hospitalization requiring transfusion. Combining multiple antithrombotic agents increase the bleeding risk significantly. Other risks include anemia, thrombocytopenia, and drug interactions. In order to minimize and manage bleeding risks, the most important step is proper patient selection, which is very crucial. For this purpose, you can consider bleeding risk scores, for example, the Has-Bet score. Close monitoring of renal and hepatic function is essential, as some anticoagulants rely on these organs for elimination, and dysfunction of these organs may interfere with the therapeutic effects of the drug, as well as they may inherently derange the coagulation profile of the patient. Dose adjustment may be necessary based on bleeding risk. This is how you can manage bleeding risk, you can prevent bleeding risk. You should be vigilant, you should carefully select your patient, you should have a close eye on the patient's renal and hepatic functions, and you can adjust the dose if needed. You can use agents that are safe in renal failure, for example Warfarin or apixaban, or you can reduce the dose if required, if clinically indicated. For how long triple antithrombotic therapies can be used? As far as the expert consensus document of the American College of Cardiology, which was published in 2020, is concerned, triple antithrombotic therapies should not be prescribed for more than 1 month. However, the optimal duration of triple antithrombotic therapy varies based on the patient's clinical condition and risk factors. In atrial fibrillation patients post-PCI, shorter triple antithrombotic duration of 4 to 6 weeks is recommended to minimize bleeding risks, and for patients with mechanical heart valves post-PCI, triple antithrombotic therapy may be extended up to 6 months. But that again depends upon the bleeding risk, risk of valve thrombosis, and ischemic risk. For that purpose, the utilization of risk scores can be of very importance. Individualized treatment plans are essential for maximizing benefits while minimizing risks. When triple antithrombotic therapies are prescribed, another feared complication is drug-drug interaction. Triple antithrombotic therapies can lead to drug-drug interactions, particularly with some medications, for example, the proton pump inhibitors affecting anticoagulant metabolism. Always consider potential interactions when prescribing triple antithrombotic therapies and adjust doses accordingly. However, there are certain alternative strategies which can be used instead of triple antithrombotic therapies. These are because triple antithrombotic therapies may not be suitable due to high bleeding risk. And the alternative strategies may include dual antithrombotic therapy, for example, DOAC plus P2Y12 inhibitor, or single agent therapy based on the patient's condition. Thank you so much. This was a brief and short outline of the use of triple antithrombotic therapy.